Hello everyone, and a very warm welcome. Today we're embarking on a fascinating journey deep inside the human body. We are going to explore the intricate and brilliant design of the female internal genitalia. This isn't just a list of parts, it's a dynamic system, a masterpiece of biological engineering that is absolutely central to human reproduction and overall health. For anyone stepping into the world of medicine, nursing, or any health science, a rock-solid understanding of this region is non-negotiable. It forms the basis of everything from routine checkups to complex surgical procedures. So, grab your notebooks, focus your minds, and let's get started on mastering this essential anatomy. Our exploration today will cover the major players within the female pelvis. We will systematically dissect the anatomy of the vagina, the uterus, the fallopian tubes, and the ovaries. Think of these as the core components of a highly sophisticated factory. Each part has a very specific job to do, but they all work together in perfect harmony. We will look at their structure, their position relative to one another, and the unique features that allow them to perform their incredible functions. Understanding this basic layout is the first and most crucial step before we can appreciate the more complex aspects of their physiology and the things that can go wrong. But it's not enough to simply know the names of these structures. As clinicians, we need to understand how they are sustained. That's why we will dedicate a significant portion of our lecture to their blood supply. We will trace the intricate network of arteries that deliver oxygen-rich blood and the veins that carry deoxygenated blood away. This vascular map is critically important, especially in surgery and when managing conditions like heavy menstrual bleeding. Knowing where the major vessels are and which organs they supply is a skill that can literally save lives and prevent catastrophic complications on the operating table. Finally, we'll connect all this anatomical knowledge to the real world of clinical practice. Why do you need to know this? We will discuss the clinical significance, linking specific anatomical features to common medical conditions, diagnostic procedures, and treatments. From understanding the spread of infections to performing a hysterectomy safely, this foundational knowledge is your bedrock. It allows you to think critically, make informed decisions, and provide the best possible care for your patients. This is where anatomy stops being a textbook subject and becomes a powerful tool in your hands. Let's dive in. Let's begin our detailed tour with the vagina. This is a remarkable fibromuscular tube that serves multiple crucial functions. It connects the cervix, which is the lower part of the uterus, to the outside of the body at the vestibule. Typically, it measures about 8 to 10 centimeters in length, but it's important to remember that it is an incredibly distensible structure. Its walls are not smooth, they are lined with folds of tissue called rugae. These folds allow the vagina to stretch significantly, which is vital for accommodating a penis during sexual intercourse and, most dramatically, for allowing the passage of a baby during childbirth. The walls of the vagina are composed of several layers, each contributing to its function. The innermost layer is a mucous membrane lined with stratified squamous epithelium. This lining is hormone-sensitive, particularly to estrogen, which helps maintain its thickness and promotes a healthy environment. Beneath this lies a layer of dense connective tissue rich in elastic fibers, giving the vagina its flexibility. This is followed by a muscularis layer composed of smooth muscle, which provides tonicity and contributes to the contractions experienced during orgasm. The outermost layer, the adventitia, is a fibrous layer that anchors the vagina to surrounding structures like the bladder and rectum. A key feature of the vaginal environment is its acidity. The epithelial cells of the vaginal lining are rich in glycogen, a type of sugar. This glycogen is metabolized by resident bacteria, most notably species of lactobacillus, which produce lactic acid. This process maintains the vaginal pH at a healthy acidic level, typically between 3.8 and 4.5. This acidic environment is a brilliant natural defense mechanism, as it creates an inhospitable setting for many pathogenic bacteria and yeasts, thereby helping to prevent infections. Disruption of this delicate balance can lead to common conditions like bacterial vaginosis or thrush. Clinically, the vagina is a site of immense importance. It is through the vagina that clinicians perform pelvic exams, take pap smears to screen for cervical cancer, and insert devices like intrauterine systems for contraception. Its close relationship with the bladder anteriorly and the rectum posteriorly is also critical. Weakness in the supporting fascia and muscles can lead to prolapse, where these organs bulge into the vaginal canal. Understanding this anatomy is therefore fundamental for gynecologists, urologists, and physiotherapists who manage these common and often distressing conditions for patients. Moving superiorly from the vagina, we encounter the uterus. This is a pear-shaped, hollow, muscular organ, and it is truly the centerpiece of the female reproductive system. Its primary role is to receive a fertilized egg, nurture the developing fetus throughout pregnancy, and then powerfully contract to expel the baby during childbirth. In a non-pregnant state, it is relatively small, measuring approximately 7.5 centimeters long, 5 centimeters wide, and 2.5 centimeters thick. It is typically tilted forward over the bladder in a position known as anteversion and anteflexion, though variations in its position are common and usually normal. The uterus is anatomically divided into three main regions. The uppermost, dome-shaped part, located above the entry points of the fallopian tubes, is called the fundus. The main central part is the body, or corpus, which constitutes the bulk of the organ. The lowest, narrowest part is the cervix, which projects down into the upper part of the vagina. The cervix itself has an internal os, opening into the uterine cavity, and an external os, opening into the vagina. This cervical canal acts as a gateway, which is usually blocked by a thick mucus plug that prevents infection but thins during ovulation to allow sperm to pass through. The wall of the uterus is composed of three distinct and highly specialized layers. The outermost layer is the perimetrium, a thin serous coat which is part of the visceral peritoneum. The middle layer, and by far the thickest, is the myometrium. This is an incredibly powerful layer of smooth muscle whose fibers are arranged in longitudinal, circular, and spiral patterns. These muscle fibers undergo massive hypertrophy, or growth, during pregnancy and are responsible for the forceful contractions of labor. The myometrium is one of the strongest muscles in the entire human body, pound for pound. The innermost layer is the endometrium, a dynamic mucous membrane that is the site of implantation for a fertilized ovum. This layer itself has two sublayers, a deep stratum basalis and a superficial stratum functionalis. The stratum basalis is a permanent layer that regenerates the layer above it. The stratum functionalis is the part that responds to the monthly hormonal cycle of estrogen and progesterone. It thickens in preparation for a potential pregnancy, and if fertilization does not occur, this functional layer is shed during menstruation. Understanding this cyclical change is fundamental to the fields of gynecology and reproductive medicine. Extending laterally from the superior corners of the uterus are the two fallopian tubes, also known as the uterine tubes or oviducts. These are narrow muscular tubes, each about 10 to 12 centimeters long. Their primary and absolutely vital function is to act as a conduit, transporting the oocyte or egg from the ovary towards the uterine cavity. Crucially, fertilization, the fusion of sperm and egg, most commonly occurs within the distal part of the fallopian tube. These tubes are therefore not just passive pipes. They are active, dynamic organs that play a critical role in the very first moments of a new life. Each fallopian tube can be divided into four distinct segments. Starting from the uterus and moving outwards, the first part is the intramural or interstitial segment, which is the narrowest part and passes through the muscular wall of the uterus. Next is the isthmus, a short, narrow, thick-walled section that links to the main body of the tube. This then widens into the ampulla, which is the longest and widest part of the tube. It is within the ampulla that fertilization typically takes place. The tube terminates in the infundibulum, a funnel-shaped opening that drapes over the ovary. The end of the infundibulum is fringed with delicate, finger-like projections called fimbriae. These fimbriae are not directly attached to the ovary, but lie in very close proximity to it. Around the time of ovulation, they become swollen with blood and actively sweep over the surface of the ovary. This sweeping motion, combined with the gentle current created by cilia within the tube, helps to capture the released oocyte and guide it into the opening of the fallopian tube. It's a beautifully coordinated mechanism designed to ensure the egg begins its journey towards the uterus successfully and doesn't get lost in the pelvic cavity. The inner lining of the fallopian tube is made of ciliated columnar epithelium. These cilia are tiny, hair-like structures that beat in a coordinated wave-like motion, creating a current that gently propels the oocyte, or the early embryo if fertilization has occurred, towards the uterus. This journey takes several days. The wall of the tube also contains smooth muscle that produces gentle peristaltic contractions, further assisting this transport. Any damage to these delicate structures, for instance from infection like pelvic inflammatory disease, can block the tube or impair ciliary function, leading to infertility or a dangerous ectopic pregnancy. Now, let's turn our attention to the ovaries. These are the female gonads, the equivalent of the testes in males. There are two of them, each an almond-shaped organ, situated on either side of the uterus in the lateral walls of the pelvic cavity. The ovaries are held in place by several ligaments, including the ovarian ligament, which tethers them to the uterus, and the suspensory ligament of the ovary, which attaches them to the pelvic wall and, importantly, carries their main blood vessels and nerves. The ovaries are true powerhouses, performing two absolutely essential functions for the body. The first and most well-known function of the ovaries is oogenesis, which is the production and release of oocytes, or eggs. A female is born with all the eggs she will ever have, stored within the ovaries as primordial follicles. From puberty until menopause, a select few of these follicles are recruited each month to mature under the influence of hormones from the pituitary gland. Typically, only one of these follicles will become dominant and rupture to release its oocyte in the process we call ovulation. This cyclical maturation and release of eggs is the cornerstone of female fertility. The second major function of the ovaries is endocrine. They are vital hormone-producing glands. The developing follicles within the ovary produce the primary female sex hormone, estrogen. Estrogen is responsible for the development of female secondary sexual characteristics, such as breast development and the typical female pattern of fat distribution. It also plays a critical role in regulating the menstrual cycle and maintaining the health of the uterus and vagina. After ovulation, the remnant of the follicle transforms into a structure called the corpus luteum, which then produces another key hormone, progesterone. Progesterone's main role is to prepare the uterus for pregnancy. It makes the endometrium receptive to implantation of a fertilized egg and helps to maintain the pregnancy in its early stages. If pregnancy does not occur, the corpus luteum degenerates. Progesterone levels fall, and this drop triggers menstruation, starting the cycle all over again. This intricate hormonal dance between the ovaries, the pituitary gland, and the uterus governs the entire menstrual cycle. Therefore, understanding the ovary's dual function as both a gamete producer and an endocrine organ is central to managing fertility, contraception, and hormonal disorders. No anatomy lecture is complete without a thorough understanding of the blood supply. The internal female genitalia have a rich and complex vascular network, primarily sourced from branches of the internal iliac artery, with a crucial contribution from the abdominal aorta. The two main arteries we need to focus on are the uterine artery and the ovarian artery. These vessels have extensive connections, or anastomoses, with each other, which provides a robust and redundant blood supply to these vital organs, ensuring they are well nourished. The uterine artery is the primary blood supply to the uterus. It arises from the anterior division of the internal iliac artery and takes a winding, tortuous path towards the uterus. This tortuosity is very important. It allows the artery to straighten and stretch as the uterus expands massively during pregnancy without compromising blood flow. The uterine artery approaches the uterus at the level of the cervix, crossing superior to the ureter. This is a critical surgical landmark, often remembered by the phrase water under the bridge, where water represents urine in the ureter and the bridge is the uterine artery. Accidental ligation of the ureter during hysterectomy is a major complication that this anatomical knowledge helps to prevent. The ovaries receive their main blood supply from the ovarian arteries. These are long paired arteries that arise directly from the abdominal aorta, just below the renal arteries. They descend towards the pelvis, traveling within the suspensory ligament of the ovary to reach the organ. The ovarian artery gives off branches that supply the ovary and the fallopian tube. Importantly, it forms a significant anastomosis with the ovarian branch of the uterine artery. This dual supply provides a safety net. If one vessel is compromised, the other can often maintain adequate perfusion to the ovary and tube. The vagina receives a more diffuse blood supply from several sources. The upper part of the vagina is supplied by the vaginal branch of the uterine artery. The middle and lower parts are supplied by the vaginal artery, which is usually a direct branch of the internal iliac artery and the internal pudendal artery. The venous drainage generally mirrors the arterial supply. The uterine veins, ovarian veins, and vaginal veins form extensive plexuses around the organs. The right ovarian vein drains directly into the inferior vena cava, while the left ovarian vein typically drains into the left renal vein first, an important anatomical asymmetry. The nerve supply to the female internal genitalia is a complex mix of autonomic and somatic nerves, which are responsible for both sensation and motor function, like muscle contraction. For simplicity, we can divide this innervation based on which part of the nervous system is involved. The autonomic nervous system, with its sympathetic and parasympathetic divisions, controls the involuntary functions like blood flow, glandular secretions, and the smooth muscle contractions of the uterus and fallopian tubes. The somatic nervous system is responsible for conscious sensation, particularly in the lower part of the vagina. The ovaries and fallopian tubes receive their nerve supply primarily from the ovarian plexus. This is a network of nerves that travels along with the ovarian artery inside the suspensory ligament. The sympathetic fibers in this plexus originate from the T10 to T11 spinal cord segments. These nerves are mainly vasomotor, controlling the diameter of the blood vessels. The pain fibers from the ovary also travel back along this pathway. This is clinically important because pain originating from the ovary, such as from a ruptured cyst or torsion, is often referred to the dermatome of T10 to T11, which is the skin around the umbilicus. The uterus and the upper part of the vagina are supplied by the uterovaginal plexus, which is a major component of the larger inferior hypogastric plexus, located deep in the pelvis. The sympathetic supply to this plexus comes from the lumbar spinal cord and travels via the superior hypogastric plexus. These nerves cause uterine contraction and vasoconstriction. The parasympathetic supply comes from the pelvic splanchnic nerves, S2 to S4. These nerves promote vasodilation and are thought to inhibit uterine contractions, although their role is less clearly defined than the sympathetics. Visceral pain from the uterine body and fundus travels back with the sympathetic fibers to the T10 to L1 spinal levels. This is why the pain of uterine contractions during the first stage of labor is often felt in the lower back and abdomen. In contrast, pain from the cervix and the upper vagina travels with the parasympathetic fibers back to the S2 to S4 spinal cord segments. This is why, as labor progresses and the cervix dilates, the pain becomes more localized to the perineum and sacral region. The lowest part of the vagina, however, is supplied by the somatic pudendal nerve, S2 to S4, which carries sharp, well-localized sensations of touch and pain. So, why have we spent all this time meticulously going through these structures, vessels, and nerves? Because this knowledge is the absolute foundation of safe and effective clinical practice in women's health. Nearly every procedure, diagnosis, and treatment plan in gynecology relies on a three-dimensional mental map of this anatomy. Let's consider a hysterectomy, the surgical removal of the uterus. A surgeon must know the exact location of the uterine artery and its critical relationship to the ureter to avoid causing devastating kidney damage. This is not theoretical, it is a real-world application of the water under the bridge principle we discussed. Understanding the lymphatic drainage of these organs is also paramount, particularly in the context of gynecological cancers. Cancers of the uterine body, cervix, and ovaries spread or metastasize in predictable patterns along lymphatic channels to specific groups of lymph nodes. Knowing these pathways allows oncologists to accurately stage the cancer, which determines the prognosis and guides treatment. For example, cervical cancer tends to spread to the internal iliac, external iliac, and obturator nodes first. Surgeons performing cancer operations must remove these nodes to check for spread and help prevent recurrence. The anatomy of the fallopian tubes has profound clinical implications. As we mentioned, pelvic inflammatory disease, often caused by sexually transmitted infections like chlamydia, can cause inflammation and scarring of the delicate tubal lining. This scarring can block the tubes, a common cause of female infertility. It can also impair the transport mechanism, increasing the risk of an ectopic pregnancy, where a fertilized egg implants in the fallopian tube instead of the uterus. This is a life-threatening emergency that requires an immediate understanding of pelvic anatomy for diagnosis and surgical management. Finally, Even routine procedures depend on this knowledge. When performing a simple pelvic examination or taking a pap smear, a clinician must understand the orientation of the vagina and cervix to insert the speculum correctly and comfortably. When managing labor, understanding the relationship between the fetal head and the maternal pelvis is key to identifying problems with descent. Knowledge of the nerve supply is essential for providing effective pain relief, such as an epidural anesthetic, which targets the specific spinal nerve roots that transmit labor pain. In every scenario, from the mundane to the critical, this anatomy is your guide. Today we have navigated the complex and elegant anatomy of the female internal genitalia. We've examined the structure and function of the vagina, the powerful uterus, the delicate fallopian tubes, and the dynamic ovaries. We have traced the vascular highways that nourish them and the intricate neural networks that control them. This system, working in concert, is responsible for some of the most fundamental aspects of human life, from the menstrual cycle to the creation of the next generation. It is a testament to incredible biological design, and as future healthcare professionals, it is your privilege and responsibility to understand it deeply. Remember that anatomy is not just a subject to be memorized for an exam, it is the language of the human body. The knowledge you have gained today provides the essential blueprint for understanding female physiology, pathology, and pharmacology. It allows you to interpret a patient's symptoms, perform a physical examination with confidence, understand imaging results, and plan safe surgical or medical interventions. This foundational knowledge will stay with you and grow throughout your entire career, forming the bedrock upon which you build your clinical expertise and judgment. The clinical correlations we've discussed are just the tip of the iceberg. As you progress in your studies and enter clinical practice, you will encounter countless scenarios where a firm grasp of this anatomy will be your greatest asset. From managing abnormal uterine bleeding and endometriosis to counseling patients on fertility and contraception, your understanding of these structures and their relationships will guide your every decision. It will empower you to provide compassionate, competent, and safe care to your patients, helping them navigate a wide range of health challenges throughout their lives. I urge you to keep revisiting this topic. Use atlases, models, and clinical cases to solidify this three-dimensional picture in your mind. Never stop asking why and how. The more you master this blueprint of female health, the more effective and confident you will become as a clinician. Thank you for your attention today. This has been a deep dive, but it's an essential one. For more clear, concise, and clinically focused anatomy and physiology videos, just like this one, make sure you hit that subscribe button for Joen Academy. We're here to help you succeed.